Hello, my name is Michael Weiner. I'm one of the emergency medicine, EMS, and disaster physicians here at UMass. Myself, along with John Broach, have created this presentation to help you get the most out of your mass casualty incident and life-saving intervention stations. To start, an MCI is an event that creates a large number of casualties, specifically a number of casualties that exceeds the available resources needed to respond adequately. Now, this could be a two-car motor vehicle accident if you're talking about a very, very small community with limited resources and this accident has a lot of impact on the surrounding community. It could be a terrorist bombing, or it could be a natural disaster with hundreds of casualties. The key is that it all depends on the available resources and the number of patients that you need to treat. The focus is, if you're in a mass casualty incident, you're going from doing the maximum good for each individual patient to doing the greatest good for the greatest number of patients that you can. The way we do that is by assessing who can benefit most from the resources that we have available to us. One way that we do that is by using triage. The most commonly used triage protocol in Massachusetts is called simple triage and rapid treatment, or START. The goal of START is to spend 30 seconds or less on each patient and put them into one of four categories: green, yellow, red, or black. That's based on the assessment of their breathing, circulation, and mental status. The way START triage works is that the rescuer begins by telling everyone to walk toward their voice or to a safe area. Everyone who does that is assumed to be green because they're awake enough to understand the command and they're healthy enough to be able to walk under their own power. The rescuer then assesses everybody else. They start by assessing if the patient is breathing. If they're not breathing, then they're dead, or black tagged, and you move on. If you have any of the following characteristics of their physiology, then they're made a red patient. Every one of these is enough alone to make you a red patient. If your respiratory rate is greater than 30, if your cap refill is greater than 2 seconds, or if you have an altered mental status. The mnemonic we use for this is 32 can do, or 30 respirations per minute, greater than 2 seconds of cap refill, and can do, in other words, can follow commands. Everyone else, meaning those who are not dead, not walking, and not red, are yellow. This is again not based on the type of injury that you have, only on the physiology and the presence of those key 3 indicators. Life-saving interventions. It's important to note that START triage is designed to be used by any level responder. LSIs, however, are used in many triage algorithms, but not all LSIs are within everybody's scope of practice. So given that START triage is designed for all levels of provider, but not all LSIs are within everybody's scope of practice, it is important to keep in mind that your scope of practice if the situation indicates a life-saving procedure. So what are these life-saving interventions? Well, these are things that should not slow you down. They should take less than 30 seconds to do. They can save somebody's life. They can really turn things around very quickly. The ones we're going to talk about in this course are basic airway maneuvers, needle decompression, stopping bleeding, and the use of auto-injector antidotes. So let's talk about airway maneuvers. When doing MCI triage, you should never do chest compressions. You should never intubate, place an IV, or give medications, or do ACLS or any of the other complicated medical procedures that you may be capable of doing under normal circumstances. Remember, if you're in an MCI, your focus is shifted from doing the maximum amount of good for each individual patient to doing the maximum amount of good for all of these patients. Each of these things I just mentioned take way too long, and they may cause you to not be able to give aid to another patient while you're trying to take care of somebody who may or may not benefit from what you're trying to do. So the first thing you can do are airway maneuvers. In MCI triage, you can only perform basic maneuvers. Again, not intubating, not placing advanced airways. These are just basically a head tilt chin lift and a jaw thrust as shown above. In children, You can give a couple of rescue breaths if you think that may help, but not more than that. So we're going to go through a little bit of each of these maneuvers, and in the course of the day, on the course of the day, you'll be able to try these out in the life-saving intervention stations. We'll go through these in more detail, and you'll have a chance to practice them on your own. So the head tilt chin lift is exactly what it sounds like. Basically, what you're trying to do is lift the tongue of the soft tissues off of the airway itself, which would then allow air to move in and out. You do that by lifting up the chin and tilting the head back, as the name suggests. A jaw thrust is another type of airway maneuver that essentially tries to accomplish the same thing, moving the soft tissues off of the airway, but should be used in patients that have potential neck trauma or where you're concerned you may injure their C-spine by doing the head tilt and chin lift maneuver. We do this maneuver very frequently in the ED. It works very well, especially during sedation, so in a very sedated patient, even if it's head trauma, this may work very well. The next life-saving intervention is called the needle decompression or needle thoracostomy. This is helpful if someone has a tension pneumothorax, as is not uncommon in blast injuries or other mass casualty incident events. One would use a 14-gauge angiocath to open the chest wall and relieve a tension pneumothorax by allowing a path of least resistance for air to escape from the space between the lung and the chest wall, called the pleural space. You do this by placing the needle through the chest above the third rib in the midclavicular line, and removing the needle to allow the catheter to stay in. Again, we'll go through the details of how to do this, but the point of this video is just to let you know that this is something that you can do, and it can be very helpful to save somebody's life depending on the situation. The next thing, and perhaps the most important of all these life-saving interventions, is bleeding control. We'll be talking about how to use a CAT, a CAT, or a combat application tourniquet in this course. But anything that will stop bleeding and is part of this larger group of measures that you can use to potentially save somebody's life. Tourniquets are a very effective way to do this because there are many commercially available types that people can use to control bleeding, and they can be stored in buildings or in a go bag or something like that. And we'll talk about the ways that these are applied, how safe they are, and the characteristics that make a good tourniquet. But for the time being, you should know that this is one thing you can do as well. Finally, let's talk about auto-injector antidotes. Specifically for this course, auto-injector antidotes are going to refer to those medications that will be used to treat nerve gas intoxications. Traditionally, the medications that we talk about are atropine and praldoxine chloride, or 2-PAM. These are used for nerve gas exposures, nerve gases being those families of intoxicants including VX gas, sarin gas, taboon gas, and a few others. The reason that these are important is that these nerve gases may be one of the commonly used agents in terrorist attacks. We'll review how to use these auto-injector antidotes and the symptoms that would be indications for their use during the course. Some of the initial, more minor symptoms of nerve gas exposure might be runny nose, difficulty breathing, eye pain, change in vision, and sweating. But they'll eventually progress to diffuse muscle cramping, muscle tremors, the severity of which may cause them to look like they're having a seizure, and eventually they could become comatose and then likely die. Nerve agents also have a mnemonic that describes their symptoms, and these are sludge and dumbbell. Sludge is salivation, lacrimation, urination, defecation, gastrointestinal pain or cramping, and emesis or vomiting. Dumbbells is defecation, urination, muscle weakness and meiosis, bradycardia, bronchuria, and bronchospasm, emesis, lacrimation, and salivation. Nerve agents are obviously very dangerous, and that's why auto-injector antidotes are a potentially very useful thing to have as part of an EMS or first responder kit, and things that you may need to use in the hospital if you're ever involved in treating victims of a nerve agent exposure. The administration of an auto-injector quickly may actually help to reverse some of these symptoms to prevent some of the progression to comatose status or potentially save their life. So these are the 4 types of life-saving interventions that will be available to you in our station to try out. Again, if you can review these beforehand, then you'll get a little bit more out of your time at these stations and get the maximum benefit out of what we're going to show you. However, don't focus too much on learning specifics on how to do them right now. We're going to go over all of that during the course. So other than that, we'll see you soon. Thanks for your attention, and it's going to be a great time. See you soon.